Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I wanted to welcome you to today's Journal Club. As always, I would like to thank ESGO and IGCS for their support in our journal. Before we begin, I just wanted to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentation. And if you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. We definitely encourage questions, so we will have times for question and answer. And please submit your questions via the chat function throughout the session today. So without further ado, I wanted to certainly welcome our speakers and authors for this journal club. This month's lead article is The Effect of Substantial Lymphovascular Space Invasion on Location of First Disease Recurrence in Surgical Stage 1 Endometrioid Endometrial Adenocarcinoma by Chris Dagher and Nadeem Abu-Rustum from the Gynecology Service in the Department of Surgery at Memorial Sloan Kettering Cancer Center in New York. So I'm very, very pleased to welcome them to join us, to thank them for accepting our invitation. So Chris and Nadeem, thank you so much for being here today. And we'll proceed with a presentation by Chris, followed by questions from our fellows, and then certainly again questions from our audience. So Nadeem, Chris, thank you so much.
Thank you, Pedro.
Thank you, Dr. Ramirez. So hello, everybody, and thank you again for inviting me once again to this amazing initiative and collaboration. So as we all know, in 2023, the FIGO released an updated classification system for endometrial cancer, which, among other changes, incorporated the extent of lymphovascular space invasion as a factor in staging. In 2024, our team, along with several others, investigated whether distinguishing between focal and extensive LVSI in surgically stage 1 endometrial cancer was associated with differences in 5-year oncological outcomes. And if you all remember that paper, we found that it was not. These findings put into question whether the upstaging tumors with LVSI, substantial LVSI, and perhaps more significantly, whether patients with focal LVSI truly have worse outcome compared to those with no LVSI at all. While it became clear to us that the presence of any level of LVSI was associated with worse prognosis, it remained unclear whether the extent of LVSI influenced the pattern of disease recurrence. And this is essentially what led us to our next study, where we aim to determine whether focal versus extensive substantial LVSI was associated with different recurrence patterns in early stage endometrial cancer. And for this, this was an international retrospective multi-institutional cohort study involving patients from 2 centers, mainly Memorial Sloan Kettering Center and Oslo University Hospital. We included patients with endometrial cancer who underwent surgical staging and were found to have FIGO 2009 stages 1A or 1B, and that received care at our institutions between the year 2012 and 2019. Staging included total hysterectomy with BSO and pathological evaluation of at least the pelvic lymph nodes bilaterally. And this is really important for us. We categorized our patients based on the extent of lymphovascular space invasion, and we divided them into 3 groups: no LVSI, focal, and substantial LVSI. And for this definition, we used the WHO classification, which considered focal LVSI as having 1 to 4 vessels involved on at least 1 pathology slide, whereas substantial LVSI as those tumors having 5 or more LVSI on at least 1 slide. And the primary goal of our study was to characterize the location of first disease recurrence using competing risk analysis while adjusting for important clinical and pathological factors. Overall, there was 1,555 patients who met the inclusion criteria. About 1,400 of which, or 88%, had no invasion. About 120 or 8% had focal lymphovascular invasion, and 65 patients or 4% had substantial invasion. We had a long median follow-up period, which was about 61 months, and the range from 1 month to 134. And overall, 21% of our population received adjuvant treatment in the form of either chemotherapy or IVRT based on national institutional guidelines. In total, there was 173 events, evaluable events amongst the 1,554 patients. One patient did not have their location of recurrence identified, so they were excluded from this analysis. Overall, we had 56 local recurrences and 43 distant recurrences, in addition to 74 deaths without documented recurrence. We found, and if we look on the right-hand side, that the 5-year cumulative incidence failure rate was about 19.5% for focal and 19.0% for substantial LVSI, compared to 6% for no lymphovascular space invasion, which is a rate of 3 times more recurrence over the course of the follow-up. And a univariate competing risk analysis revealed differences in recurrence patterns according to the extent of LVSI, as seen in the diagrams on top. The pyramid diagrams on the bottom visually represents the results of the multivariate competing risk analysis, focusing on the extent of lymphovascular invasion. And we found that focal invasion was associated with an increased rate of both local and distant recurrences, which is reflected by the triangular growth being even in all directions. Indicating that no pattern of recurrence really predominates in this group. However, in contrast, substantial invasion and lymphovascular space invasion demonstrated a non-uniform increase in the risk across the 3 axes, with a significant tendency towards distant recurrences. Our multivariate analysis reinforced the significance of established pathological factors in endometrial cancer, specifically tumor grade and depth of environmental invasion. Importantly, it underscored the magnitude of their effect within the subgroup of patients with substantial LVSI, where these features we found to be more commonly observed. So in conclusion, in the study of patients with stage 1 endometrial cancer who were surgically staged and found to have negative nodes, the detection of lymphovascular invasion, regardless of its extent, was associated with a 3-fold increase in the 5-year cumulative incidence failure rate, compared to no detection of lymphovascular space invasion. And patients with substantial LVSI had more deeply invasive and the higher grade tumors, and the frequent co-occurrence of these high-risk factors in patients with substantial LVSI likely compounds the risk of distant recurrence seen in this group. These findings challenge the current FIGO staging classification that combines no and focal LVSI into a single risk group category. With this, I tend to thank my mentor, Dr. Abu-Rustum, Dr. Anagerda Erickson, and all the teams, our pathology department, and all of the medical oncologists at Memorial Sloan Kettering. And I also want to say a big thank you to Oslo University Hospital, Pernell, Dr. Anagerda Erickson, and Dr. Davidson for their amazing collaboration. And finally, I want to acknowledge Bob's Foundation for sponsoring my fellowship here and my research.
Excellent. So Chris, thank you so much for that presentation. Thank you actually for putting those slides together. I know that we all would like to have those slides for future presentation. And again, thank you, Nadeem, for joining, and Pernille representing the Norwegian Radium Hospital. So also, Pernille, feel free to provide your input. I'm also very impressed that we actually have several members who have AI assistants taking notes from this journal club. So it's a wonderful luxury to have, to actually just send your AI assistant to take the notes while you're busy doing something else. So that's really wonderful. So of course, now we get to the discussion. And again, I want to invite those who are joining us to send in your questions via chat. But we'll start with questions from our fellows. And the first question comes to us from Canada, University of Toronto, Stephanie Gill.
Awesome. Well, thank you so much for your excellent presentation and congratulations on your publication. To start off the questions, my question for you is, I did find it interesting that prior studies used different vessel cutoffs to define the LVSI categories, especially given that the WHO classification is available. So given the different LVSI cutoffs used in different studies, which could be due to institutional or pathology guidelines at those institutions, do you think that pathologists and different institutions would be opposed to adopting the WHO cutoffs used in this study, and why or why not?
Thank you very much for this question, and thanks, Pedro, again for giving us the opportunity to present. So this is an excellent question, and traditionally LVSI is reported as present or absent. That's how it was done for many, many years. In the last 10 to 15 years, there was this movement to try to quantify the amount of lymphovascular space invasion. Initially, it was described as diffuse or multifocal, and then we used a one vessel cutoff. And then with time, pathologists, mostly driven by research done with the Portec group with Jaling Bossi, to try to use cutoffs like 2 vessel, 3 vessel, 4 vessel. The WHO definition, it's very important to know that this definition came by consensus from experts. It was not based on data. So there was a consensus among expert pathologists, and they chose this cutoff of 5 or more. So it's very important for us to know how this came about. And the research that we published last year and this paper, which is a follow-up paper to that, are the first definitions papers using that specific definition in surgically staged patients. So to answer your question, I think people will use the WHO definition, but it's important to know that that definition was not based on scientific data, which is unfortunate. And maybe now with the emergence of more data, there will be reconsideration for that. Thank you.
Excellent. Thank you so much, Nadeem. I don't know, Chris, if you would like to add anything else, or Pernille?
I think Dr. Abu-Rustum just summarized the entire conundrum really perfectly and beautifully. Hopefully there will be like standardization going forward to how do we analyze and report LVSI, and that could basically just standardize our results, and then could basically like derive conclusions from that.
Yeah, exactly. And our pathologists actually went through all the slides that were included to actually check and make sure the numbers of vessels were correct, to reassure about this, because it's a very important question. Thank you.
And
One last
comment,
Pedro, is they always look at the supplements in these papers, and in this paper, supplement table 3 is very important, because it will show you how many vessels were counted, how many patients had 1 vessel, 2 vessel, 3 vessels. So it'll give you a really nice picture of the distribution of the number of LVSIs, and kind of makes you think that there's really no absolute place where you can make this cutoff. So if you have an opportunity, look at supplement table 3.
Excellent. Very well. Thank you for adding that, Nadeem. Next, we'll go to Madison, Wisconsin, and Julia Gellison. Your turn for the question.
Thank you guys for taking the time to share your findings with us. I was wondering how you think about the fact that patients with substantial lymphovascular space invasion had higher rates of full lymphadenectomy, and if you think that that may have impacted your findings, as well as if you know if the higher rates of full lymphadenectomy were because these patients were more likely to have failed sentinel lymph node mapping.
All right, thank you so much, Julia, for that question. I have to say that the observed high rate of systematic lymphadenectomy and lower use of sentinel lymph node biopsy in the patients with substantial LVSI in this particular situation likely reflects an institutional and national practice pattern rather than it being a direct causal relationship with LVSI itself. We have to know that a significant proportion of the patients with substantial LVSI in our cohort have received care in Norway, where systematic lymphadenectomy remained the standard of practice through 2019. Although SLN mapping began gaining traction in Europe during mid to late 2010s, its adoption varied widely across the country and institutions, across countries and institutions. And particularly, and correct me if I'm wrong, Pernil, in Norway, the implementation of SLN mapping was relatively limited during the study period, which goes from 2012 to 2019. Which likely contributed to the observed differences in nodal assessment strategies across the LVSI subgroup. The question of whether patients with substantial LVSI are more likely to fail mapping is an intriguing one, I have to say. I think like one could hypothesize perhaps that extensive tumor emboli within the lymphatics could potentially impede the dye from reaching the nodes, but that would be like an amazing hypothesis to test in future work. So there you go, a research hypothesis.
Excellent. Very, very well. Pernil, anything you want to add?
Yeah, you're absolutely right, Chris. So we started from the summer of 2017 doing SLN at our department. So we implemented it for intermediate and high-risk patients, which are not mainly the ones in this paper. So yeah, that's the reason.
Excellent.
One
So
of
we have a question from the audience, and Natalia Zef, and she's asking, great publication. And her question is, were the patients categorized by molecular profile as well? And if so, was it considered a multivariate analysis?
All right. Dr. Abu-Rustum, feel free to jump in at any point, but I can start with saying that unfortunately for this project itself, when it was thought about and then planned for with the collaboration with Norway, we did not take into account to introduce molecular subtyping for this cohort of patients, particularly knowing that patients in this subgroup would have not had undergone necessarily molecular subtyping, especially during the years between 2012 and 2019. And wanted to be very mindful that we don't bias our results towards a certain subgroup of patients. And we all know that in this very low risk group of people, cohort of people, the molecular classification will be in around the rate of 20 to 30%. But it could be a really important project for the future.
Yeah. Nadeem, any additional comments on that?
The only thing I would add is in our department, we did not start comprehensive molecular profiling routinely until 2016. So from 2016 on, we have comprehensive molecular profiling on every patient if they agree to that. So this study goes back 2012. So we don't have all that data.
Excellent. Another question from the audience, actually two questions. Albert Jacob, he says, I have two questions. Was there any further stratification on the site of local or distant recurrence? And if yes, was there any site which was much more strongly associated with focal or substantial LVSI? I'll let you answer that one first and then get to the second question.
So we do have a like a rundown of all the locations based on the LVSI subgroup in the supplementary tables. I think people would really benefit from looking into the supplementary tables. We cannot put everything in the main paper. We could not really identify that there is like one particular site that is more associated with substantial or focal, but we do know that from our multivariate competing risk analysis, substantial, like compared to no LVSI, was significantly associated with distant recurrence in general. And we have to be mindful also that the numbers, the more we do these kind of like subgroups, the numbers are going to become smaller and smaller. So doing meaningful analysis is going to be very limited.
Very well. And the second question is, can you explain why focal LVSI correlates with local recurrence and substantial LVSI correlates with distant recurrence?
This is a good question, and we're just learning this. I mean, this paper with Chris and Pernil, I think, was the first one to really bring this out. And you have to remember, we don't need to look at these things in isolation. So when we're talking 5 or more vessel involvement, it's not in isolation. These patients have more deeply invasive tumor. About 54% of those patients had deep myoinvasion. About a third had grade 3 tumors. So it's well known that deep myoinvasion and high grade are associated with distant recurrence. So I think finding 5 or more vessel involvement comes with other uterine risk factors that are well known to be associated with distant metastasis.
Very well. Excellent. Well, now getting back to questions from our fellows, we'll get to Vienna, Austria. Thomas Bartel.
Thank you. My question somewhat goes in a similar direction as Julia's, as you mentioned, potential differences between the two centers. My question is, did results remain stable if centers were analyzed individually? Meaning, did the overall numbers of involved vessels differ between the two centers? And did observed survival outcomes according to LVSI status differ between the centers?
Thank you so much, Thomas. That's a really insightful, important question. For the comparison between the two centers, we did present the survival data and the results of the sensitivity analysis during ESCO 2024. And I believe the slides are available on the platform for everyone to review. Now, despite differences in clinical pathological characteristics like Pernil has alluded to and I've spoken about earlier on during this journal club, the survival outcomes according to LVSI status were consistent across both sites, which supports the robustness and generalizability of our findings. As for the numbers of the vessels involved, a direct numerical comparison between both centers wasn't feasible, as detailed vessel counts were only available for the newer cohort. That being said, it had to do with how we devised the plan and how we planned to do the study initially. We did not account in our IRB to share the numbers of the vessels. So when we devised that whole study back in 2022, we did not really ask for both centers to count the numbers. So this is why this has been limited. We did share from our center the number of vessels involved, but unfortunately we cannot compare head to head between two centers.
Very well. So we'll turn now to Kara Fischer. She's in Heidelberg. If you have any follow-up questions about Oliver Savanovic, Nadeem, please feel free to ask Kara and see how he's doing. So Kara?
She is actually not able to make it, so I'm going to ask her question on her behalf.
Elise Yates from Houston.
Sorry. Her question is, you mentioned that there are significant differences in other risk factors for recurrence, like tumor grade and depth of myometrial invasion between the no LVSI, focal LVSI, and substantial LVSI groups. This makes it difficult to determine how much of the recurrence risk is actually due to the LVSI itself. Would it be possible to better isolate the effect of LVSI using methods like propensity score matching?
So that's a really important question. And I think the difference between using propensity score matching and multivariate analysis, because both of them are going to look for confounding factors, right? The only issue with using propensity score matching in this cohort is that sometimes if you have a subgroup that is really exclusive, you might end up with few numbers that could match to that cohort. So eventually that would render your analysis very limited. And this is why when we were discussing with our statisticians, they were more in favor of doing multivariate analysis and adjusting for differences in centers. And this is what prompted us to use the multivariate analysis instead of propensity score matching.
Very well. Thank you, Elise, for asking Kira's question. And now we turn to Valencia in Spain. Manel Montesinos Albert.
Thank you and congratulations for your work. Given the potential impact of lymphovascular space invasion on tumor spread, could a future study investigate the possible correlation between its presence and an increased rate of sentinel lymph node migration to better understand its role in nodal dissemination?
Yeah, this is an excellent question. In this study, we excluded any patient with positive sentinel nodes, including isolated tumor cells. But your question is very good, and it could be a new project for any of you that's interested. You would take a cohort of patients who have positive sentinel nodes, including ITCs, and then you can go back and have pathology review and see was there any LVSI, and if there was LVSI, try to quantitate it and look at other uterine factors. So it's a very nice project, but it's not possible to answer this question from this data because we have no positive nodes in this cohort. But it's a very interesting research question. Thank you.
There you go, Manil. An easy one for you. All right, so we'll go to the questions from the audience. Payam Kashi, outstanding work. Congratulations. Excellent presentation, Chris. Congrats to the team at MSK and Radium Hospital. What do you see as the clinical implications of treating patients in developing countries where molecular testing and stratification is lacking? Is it possible for these patients to help identify high-risk patients and provide options for neoadjuvant therapy?
So I would like to address this. In this manuscript and the one before, we are describing that patients with any LVSI are at 3 times increased risk over folks with no LVSI. But in no way we are making recommendation for any adjuvant therapy. So we have to be very careful. When we find risk factors for increased recurrence, that does not necessarily mean that adding additional treatment in the form of radiation or chemo will automatically make that better. We would like that to be the case, but this research does not in any way endorse more radiation or more chemotherapy to change that 19 to 20% risk of recurrence. So this is a very important question and a very important message. All we're saying is that patients with LVSI have increased risk of both local and distal recurrence, but that doesn't mean that giving them chemotherapy or radiation may change that. That's to be determined.
Excellent, excellent point, Nadeem. Thank you for that. And next we'll go to Christian Brown.
Thank you for your excellent work and for the clear and insightful presentation. So my question goes in the same direction to the adjuvant treatment. In this cohort of patients with negative pelvic lymph nodes, the rate of para-aortic lymph node recurrence was markedly higher in patients with substantial LVSI compared to those with no LVSI. So maybe should we consider a secondary para-aortic lymph node staging to better tailor adjuvant treatment in patients with substantial LVSI?
So thank you again, and thanks for looking at the data so carefully. So with the concept of SLN mapping focusing mostly on the pelvis, as you know, we live with an isolated periodic recurrence of anywhere from 1 to 3%. So that's something that we've lived with. In this data set in supplemental table 3, you can see that isolated periodic, there were 3 patients in the substantial LVSI group who had isolated periodic nodal recurrence. But remember, this is also in the setting of more likely deep myoinvasion and higher grade. And there is some suggestion in the literature that deeply invasive tumors, particularly high grade, may have more of an isolated periodic nodal recurrence. Now, this percentage, not sure that it would justify us to take 95 patients to surgery to do periodic nodal dissection to possibly find that low rate of isolated metastasis. You also have to remember that moving forward with the addition of molecular profiling, a significant number of these patients may fit into criteria where systemic therapy may be indicated. We're not there yet, but it is possible. So those 3 patients that had isolated periodic metastasis in the substantial LVSI, that possibly is the highest rate we will see, and maybe even less as time goes on. So at this moment, I think it's an excellent question, but I'm not sure that I would endorse taking those patients back just for periodic staging. You may say, if you meet those criteria, I'm going to watch you more carefully. I may image you a couple of times a year. I think that's reasonable, Christian.
Excellent. So now, Elise Yates from Houston Methodist.
Thank you all for your time today. My question kind of goes in line with the first question that we had. It is, based on these findings, do you think the current WHO method for categorizing LVSI into focal or substantial is effective and useful?
Thank you, Elise, for this question. I think it's becoming very important for people to know how to move forward. But before we can fully evaluate the effectiveness of the current WHO method for categorizing LVSI, it's critical to acknowledge some of the inherent challenges in LVSI assessment. First, there's notable heterogeneity in how LVSI is identified. There's a lot of inter-observer variability among pathologists, which remains a big concern even within experienced centers. So the assessment can also be limited by sampling issues. Representative sections may not always capture the true extent of the invasion and may not be actually capturing the slide that has the most invasion on it. So there's always this kind of unknown factor going on there, particularly in a larger or more heterogeneous tumor. That said, I want to highlight the considerable effort being made by the pathology community to standardize the LVSI assessment recently. And I think a big thank you goes to FIGO 2023 in promulgating that effort. And ongoing initiatives to develop clearer histological criteria, consensus guidelines, and educational efforts are moving us closer to more reproducible and reliable classification. In my view, once LVSI evaluation is consistently standardized across institutions, and once we have a sufficient number of high-quality studies that use those uniform criteria, only then we can truly assess the utility of a prognostic marker or like looking at specific LVSI cutoffs, whether it be quantitative or semi-quantitative. But I think we still lack those large studies, and I'm hopeful that in the future we can get to that point.
Excellent. Thank you, Chris. And then we'll go to University of Padua, Matteo Marchetti, who's going to ask a totally non-controversial question. Matteo.
Thank you for your amazing job, amazing paper. My question is in continuity with Elisa's one. You suggested in the conclusion that LVSI quantification in FIGO 2023 classification should be reconsidered. But do you mean remove it entirely, or rather modifying the staging system to introduce a specific category for focal LVSI, or possibly grouping them differently with no LVSI on one side and focal or substantial LVSI on the other, for instance, within stage 2B? So personally, I sometimes feel that FIGO staging is increasingly resembling a risk classification system rather than a true staging system, with grade 3, as you mentioned in the paper, now standing out as the only missing independent prognostic factor. Thank you.
Who wants to take on this easy question?
I'll take it. Thank you, Matteo, and thank you, Pedro. So your comment is very valid and very true. Any changes in the FIGO staging will have to come from the FIGO endometrial cancer subcommittee, and this is usually done over many years. What this data is doing is trying to give the subcommittee and any future committee that's working on endometrial cancer more evidence in surgically staged patients to try to help with those decisions that you mentioned. Your comment is very valid because there has to be some distinction when you're trying to create a prognostic model. So staging could be simplified, but you can still have prognostic factors that are in a separate table, or more ideally in a nomogram. So you can build a nomogram that's very powerful and very prognostic, and you can put age and grade and myoinvasion and LVSI and molecular profile and lymph node status, and you can make it as big and as complex as you want. And that could be a prediction model that could be used on an app or a calculator, and that's a perfect prediction model, and there are models like that available. Staging systems should be more simple. You cannot include everything in a staging system. So one way to answer your question would be, at this point, LVSI as a measurement and quantification is very controversial and not standardized, and may be very difficult for the larger global community of GYN pathologists. So it may be very reasonable to add it as a prognostic factor in a separate table and keep the staging system more anatomic. So by doing this, like we would do with age is very important in endometrial cancer, but we don't include it in staging. Washings are important. We don't include them in staging. So there has to be a way in the future to keep those important prognostic factors, but they don't necessarily need to be in the staging. And again, the best way to create a prediction model is with a nomogram. Thank you.
Very well. Excellent. So now we'll get to our last question from Clara Santia, who's now in Buenos Aires, Argentina.
Thank you. Congratulations to the whole team for this work, and thank you for the opportunity to discuss your article with us. And my question is, how does the presence of lymphovascular space invasion, whether focal or substantial, impact your daily clinical practice? Additionally, do you have any data or insights on the correlation between lymphovascular space invasion and the integration of molecular classification in this tumor? I know that you answered some of these before.
Thank you so much, Clara, for these questions. So at this point, for us and our own department, we look at, after doing this research for a couple of years now, we look at LVSI as detected or not detected, present or absent. Our pathologists are continuing to count and report because I think it's an important research question. But from a management standpoint, we are not doing anything different if somebody has 5-vessel involvement or 4-vessel involvement or 3-vessel involvement. Whether this will change in the future, it's possible. At this point, from a management standpoint, we have LVSI or we don't have LVSI. We are at a point now where we have a large body of patients that have complete molecular profiling and LVSI status that's quantitative. So again, this will be another project that will probably appear in the near future when we have more fellows with more time. Maybe Pernille will take this on in the next. But thank you for the question.
That's outstanding. Pernille?
Yeah, it's the same at the Norwegian Radium Hospital. We don't use it for, in the terms of how we treat patients with terms of adjuvant therapy. But I always note it, what it is and comment on it, but we never use it for practical terms of decide what to do. That's decided on other factors.
Outstanding. Well, thank you all so much. And Nadeem, as always, a pleasure to see you. I think, Nadeem, everybody's wondering, and perhaps you can briefly explain what's with the hammer in the back and the wall.
Oh, thank you. I didn't know you could see that. I guess you can. Well, one of my hobbies is carpentry. So the staff here got me a hammer. So I like to work on my free time with carpentry. So that's
so not for fellows who don't fulfill their duties in terms of papers.
I will have Dr. Leteo take care of that.
Exactly, and he does it very well. So thank you again. Thank you for joining. Thanks for the fellows for formulating their questions. For all of you who submitted the questions, I want to thank the AI scribes as well for attending our journal club. Please do remember to join us in May Journal Club to discuss genomic alterations, molecularly targeted therapy, and survival, a real-world endometrial cancer molecularly targeted therapy consortium with Angeles Secord, and we're really looking forward to that journal club. So thank you once again for joining us.
Thank you so much, Pedro. Thanks, everybody. Bye-bye.